since we are still hybrid, go around the room, just maybe say your name real quick and potentially region and agency, just so we know a little bit more. And then we'll dive into kind of the content of the workshop. So I'm Eric Lang, I'm with N-CATT, but if you want to take it away. Great, thank you.
Hi, this is Mauricio Orozco from Care First Health Plan.
This is Jane Lang, and I'm the former director of the Senior Health Program at the Arizona Department of Health Services.
My name is Jason Snee, and I'm with the Arizona Developmental Disabilities Planning Council. I'm the Research and Communication Specialist.
Maria Reboso, Cultural Care Manager for Equality Health.
Eric Barr, CEO with Elaine Transportation.
Hi, everybody. This is Andrew Renda. I'm the VP of Population Health for Humana.
All right, I think that's everyone, and more come in, we'll let them chime in. So this is really however we want to take this in under the umbrella of Healthcare Transportation Task Force. So that can look a couple different ways. And of course, we have this guiding document, but we don't have to stick to it. So kind of thought we could just jump right in with the problem and opportunity statement before we go on to kind of the next bullet points. Oh, sorry, Sam, you're on the screen.
Yes, can you all hear me?
Yes.
Sam Johnson, Operations Specialist, also with Elaine Transportation.
Great, thanks, Sam. All right, so problem opportunity statement. So this one's kind of high level, but what do you see are under this kind of umbrella Healthcare Transportation Task Force are the problems, but also an opportunity to do what? Feel free to just unmute yourself and chime in.
Well, I think one of my comments from earlier was that it's more about access. I think through all of this, we're trying to help people access care, whether we're bringing them to a healthcare facility or we're bringing a clinician to them or we're providing virtual care. So to me, the problem statement is about creating better access and maybe also figuring out what an individual needs or wants at a given time. Because I think it's like someone else said, it's not a one size fits all, all people all the time, whatever that phrase was. I think it's what they need, what they want, what they'll engage with, what's going to help their health outcomes.
Yeah, I think to go with what the previous person said, it's more about just connecting the dots. Because I think there's people out there that are willing to help. You just have to connect them to the right, services or.
I'd like to bring up, it's actually two different problems, but they're the inverses of each other. So I'm seeing basically in medical transportation, two different primary approaches. One is like the immediate ASAP rides via Uber, Lyft, Veo, the sort of rideshare model. The issue there with those, though, is that oftentimes Uber drivers are just not trained for the type of ride that is required. Like Uber Medical, those are just regular Uber drivers. They might have been on the job for about a week. So then on the other hand, we have NENT, scheduled rides, more specialized transportation support, but that's scheduled out in advance. And there are a lot of challenges around scheduling out in advance for transportation. So what we've been trying to think about is just how could we combine the best of both worlds? How can we have ASAP rides that work really well and that can be ordered when they're needed with the highly trained specialized services?
Sorry, I'm just kind of quickly trying to facilitate and take notes here. So just make sure it's a little small, but can you see it on the screen okay, Sam?
Yes.
How does everybody else see this in the room? Is that okay? Is that legible for folks? Okay, great. So how can we kind of do best of both?
Can I add another one?
Absolutely.
It's also how the community sees or perceives these organizations. A lot of the times they are seen as, like somebody mentioned in our earlier, they don't come and pick me up on time. They take too long. So it's also how they are perceived by the community.
I say that might be more than perception with certain
I
names.
didn't want to offend anybody. But yes.
Along with the Uber drivers that Sam mentioned, also the accessibility to those. I mean, some of those Uber drivers don't have the lifts or the capability to take somebody like myself to wherever I need to go. So even if it's not healthcare, it's something else. But anyway.
So you want?
Thank you. We work on tribal lands, Navajo Reservation, Hopi Reservation, San Juan Southern Paiute Reservation, and we have more issues than just, what's up there. And in terms that we have more in terms of NEMTs will not make it out to the homes because of bad roads, because they just they don't want to, because they're responsible for their own maintenance of their own cars. So a lot of them just find it too much to try to drive these bad roads all the time. Even caretakers don't even make it out to the homes because of bad roads. So I think on tribal lands, telemedicine might be a better option for most people. But again, broadband, the lack of access to internet is a whole nother issue, or even phone reception is another issue. So it's like we have more issues than just this. There's no Ubers, there's no taxis. So I don't know.
I think one of the areas, if we look at all of the little stickies on there, is better coordination. I think whether it's a tool that we use or communication tracking, as I mentioned earlier, and I think it was brought up here, the lack of training. Honestly, being a health plan, I think all of the health plans kind of contract with a transportation broker to provide transportation services for their members. But from my own personal experience, I find that the community-based organizations probably have better training than going through like a transportation broker, because usually what happens when you go through a transportation broker, they partner with like a taxi company, right? And they may or may not have the best training. They may or may not have some of the language barriers or even the customer service skills to be able to deal with our members and the population that they're trying to serve. So I don't know how you come up with a solution to that. My thought is making it easier for those CBOs or nonprofit organizations or volunteer organizations, making it easier for them to kind of contract with the health plans directly, because it seems like they're more mindful of the population that they're serving and there's better training.
And I'll say, sorry. Off of that, I think there's tremendous value in ensuring that it is that collaborative partnership, and there's the sharing of quantitative and qualitative data on a regular basis. And that's something that both Sam and I have really learned along the way that really builds a strong program, is when it is a true collaboration, when we're talking frequently about what's working really well. We have a contract with Honor Health to provide patients to one of their hospitals with transportation, whether it's home to shelter, after they're discharged from the hospital, picking up medications, follow-up appointments, and ensuring that we're the preventative service, so they're not getting readmitted into the hospitals. But that takes a lot of working together, and we have a limited capacity as such a small organization. But as opposed to just, I don't want to speak for other transportation services or partnerships or contracts anybody else has, but we've seen that model has tend to work really well as opposed to just kind of getting one-off rides here and there, because I think that sharing of data and that really working together is what's going to build a partnership to where we understand what the gaps are, what the needs are, how we can adjust and pivot our services to best serve the clients, as opposed to kind of being just a drop off point A to point B service.
Hello, this is Eileen again. Let me tell you a little bit about our program. We're a Center for Independent Living. If you're familiar with Ability 360, where there's 5 in Arizona and we're one of them, but we're located on the reservations. And we do have a transportation program. Some of the things that was talked about in the other room before we came in was what we do, our staff does is they go out to rural communities, and we have a fleet about 5-6 cars, and offer education and a lot of medical education, a lot of people with diabetes, heart issues, and various disabilities, and try to help them manage their whatever it is they have that they have to deal with, and so they can live longer, I guess, in their own homes or stay in their own homes for as long as possible. But we're just we're doing all this on our own, what little funding we get from ACL. And what caught my attention was someone was talking about the education from American Diabetes Association. That's a billable hour, she was saying. And we would love to provide some services for medical clinics or hospitals and be paid to do that. I mean, we're already in the communities anyways. And we do offer transportation to like maybe 100-mile radius. And we do pick up medications for people. We pick up food boxes. We actually do a lot of things that maybe we could be using as a fee-for-service program. That would be wonderful, give us extra monies to be able to use for other things. That most of the time it just goes right back into the program, and it's used for more people. So that's just what I was thinking, is we already do a lot of the work. We do transportation. Right now, we just have 2 contracts. One is with the Tuba City Regional Health, a hospital, and I could understand the Z codes they were talking about. We had such a problem with that because we normally bill to Tuba City Regional Health, and their contract hospital 638. So I guess they don't really, they change the codes. I'm very sure somebody checks them and changes them, and they don't make a big deal out of it. So they never said anything to us. And recently we did one transportation for one individual from an IHS hospital, and they made a big deal out of it. They would not pay us. They haven't paid us for 6 months because they said we're using the wrong codes, but they wouldn't tell us what codes either. So this has been going on for months. So what I heard in that other room, somebody was talking about having, learning more about Z codes. That's what we need. That's what we're very interested in. But other than that, we do have a contract with Kaizen Health Medicare Transportation, and that finally started picking up for us in the last few weeks. And I think before it wasn't picking up because I think they were going through the NEMTs. And what happens is NEMTs start joining on. And I think what happens is they get tired of the roads, everything that it just builds up on them, and then they stop, they drop back. But we're doing as much as we can that we can afford to do in terms of nearby areas. So that seems to be working well for us. But we would love to look at more services in terms of, transportation contracts with directly with, because for some reason, we're not able to be NEMTs. but we're picking up contracts where we can, in terms of doing, we do have a grant from ADOT, we're a 5310 program. So, and we've been doing that for quite a while now. So it's working for us, but we would love to learn more about everything that we can do to help more folks on rural outlying areas and still be able to do everything we're doing right now. So thank you. Assist to independence from Tubi City.
I think, go ahead.
I think in terms of opportunity statement, it's an opportunity for us to bring in, I guess, like the independent living centers, like Elena was saying, and people with disabilities. Because each area, each person with a disability has their own problems, or even Native people that understand the community and can provide better community service than just a transportation company that doesn't understand the unique needs of that community. So I think this is an opportunity to bring in those partners to make it more accessible for everyone. That was just about it.
I think I'm so happy because I learned a lot from what you said, and that might be an opportunity actually. Because sometimes as a health plan, we think about sponsorships or things like that. But sometimes technical assistance has a lot more value. Maybe grant writers, because when you work for a CBO, a nonprofit, you wear 10 different hats, right? And not everyone is a grant writer, but somehow it falls on someone within the organization that just does it because, but someone that has the experience in contracting, grant writing, technical assistance, so they can be that bridge between the CBOs and healthcare. That might be a better investment in helping those CBOs that are better trained, that have the volunteer base, but they don't really have the knowledge of dealing with government contracts and regulatory things. And I think that would be probably a good idea to invest in that technical assistance that's needed from the CBO side.
Well, that is such a huge need. And I'm sorry, I keep bringing my company back again, but that's one of the things that we help our partners, our CBOs that partner up with us. We help them with their grant writing, whether it's just writing a portion of it, because a lot of it has to be done by the actual not-for-profit. But there's a big component with the data and all the information. And so we help them because like you said, there is a huge need for these smaller entities that just can't hire somebody. Or even finding the monies where, finding these monies that are out there where they can write the grants. So I think that's a huge part of it. Because I don't know if you're a not-for-profit. You are. So that's perfect. You could even benefit from that as well. So, but even if you weren't, there's a way to write for grants as well. So you partner up with another organization.
So I'm hearing that there's, a number of needs depending on your sector and capacity and things like that. So, and we are about 20 minutes into this session. So I want to just we come back to kind of more of the fine grain stuff. I wanted to just focus on kind of what the task force exactly is. So kind of what I'm hearing, and we could continue to workshop this a little bit, but because of a lack of coordination and we could say capacity and other things, we have an opportunity to kind of come together, develop a network, create our own resource, I guess, essentially across the state of Arizona. Does that resonate with the audience here? We can continue to kind of workshop the language here, but does that give us a good sense? Yeah, Sam.
Yeah, it does. And I want to say that for this exact reason, I was on the fence between attending this breakout room or the communication breakout room, because this is exactly what we've been saying as well, that we need, I want to almost call it like a centralized dispatch or a centralized resource referral platform. We've been in talks with Unite Us, we've been in talks with 211 and Solari to figure out what that could potentially look like in our community, and if that's something that would be scalable as well.
I agree with that. I think from the brief presentations that we had this morning, it seems to me, Elaine and the Verde Valley Coalition, they have gold standard models, what I would consider gold standard, where they go above and beyond just transportation, but transportation is the main focus. Why don't we learn from those? I'm sure they've gone through a lot of lessons learned. Why don't we stick to those models that we know that are working in the community, and how do we introduce those into those other areas where they're lacking those type of programs or services? I know they got to be tweaked according to the community needs, but the general, the way you operate, the way you train people, the people that you hire, all of those things that we can learn from. You guys already have gone through those growing pains, and I think using those lessons learned would be valuable for other CBOs that are thinking or might be doing the same thing, but they're not as advanced or coordinated as you guys are at this point.
My thought on this is that a goal of a task force isn't necessarily to create a product. I feel like the communications group was more about creating a product to communicate between different stakeholders. But what we could do through a task force is take an ecosystem kind of approach. And the whole idea would be to create a transportation ecosystem that involves all the stakeholders. So you've got health plans and you've got transportation organizations and technical organizations that all sort of talk about what are the key pipes we need to build and connection points. So some of that may be data and Z code. Some of it may be, what government organizations are we working with, but just creating that ecosystem with a task force with representation from all the different kind of elements.
There are state agencies too that could play a part in the coordination of these things. There is a Governor's Council on Aging that has a lot of influence. They don't have money, but they have a lot of influence in the rural areas of the state. And there is Arizona Department of Health Services. They have an outreach for the older population. And of course, the Department of Economic Security, they have the Aging and Adult Administration, and they get all the Arizona Title III money from the Older Americans Act. And so these players could help in the coordination of these efforts and pull them together because they're aware of what's going on throughout the state and what's available.
One of the things that comes to mind is when we talk about transportation, it seems like we look at subgroups within the transportation, but I'm wondering if transportation, as you were mentioning, is for all, because we tend to focus on seniors, which is great, but what about the ones that are not seniors? We're talking about the Medicaid population that has family and children. Then you have maybe another subgroup under that, which is the unsheltered or homeless people that may not be seniors, they may not have a family, but they also need transportation. So you have subgroups under the transportation umbrella. And it seems that in itself is kind of siloed. And I know it's probably because there's regulations and things that need to be followed, but I think transportation is like applies to everybody, not just to seniors or Medicaid, or, you know what I mean? How do we bring those resources together? Because if there are resources that maybe are for seniors that are being underutilized, maybe there's an opportunity there, or maybe the same for the Medicaid population, unsheltered population. I mean, I don't know. How do we, the ecosystem that you're talking about might create that?
I would love to just jump in and second that, because at Elaine, that is one of the most challenging things we've had to overcome. We technically serve anyone with a barrier to transportation. That's our service criterion. And as you can imagine, that covers a wide range of people. There are many, many folks out there with significant barriers to transportation who don't necessarily fit into a neat box, if that makes sense.
It has been, and I'm glad you brought that up, and thank you for the kind words. It has been an interesting learning process for us as well, serving individuals experiencing homelessness in other vulnerable communities and figuring out, especially as a smaller team, how do we build our services and programs around different populations and different priorities, just in terms of what types of rides do we see, I guess, from our vantage point, what are other nonprofits seeing, what are other entities seeing, that maybe it's, housing or, healthcare, to just bring it around healthcare, but what types of healthcare appointment rides maybe should be prioritized. And so that's where we back to, kind of the partnerships and collaborations, is it really is helpful for us to have those conversations as to what everybody else is really seeing as the highest needs, the most critical needs. Where can transportation have the most impactful outcomes as it pertains to transportation? So this is really helpful for us, but I think even just helping kind of narrow that focus, and just if it's focusing on different subsets of populations within, healthcare transportation services, or, whatever it is, because Elaine will continue to be providing transportation around all social determinants of health, but even specifically on healthcare, how can we fill the gap and not overlap with other resources and that are already being provided as well? So
That's a great point, and also a great segue. We can always come back to this because there's, I think, a lot to it, but I think we've kind of hit kind of a consensus on what this might look like. And one thing that we wanted to address with this, to your point, is not duplicating what exists or overlapping of resources and things like that. So my sense is that this doesn't exactly exist, which is why we chose to put it on the board. But does this exist in, like we were saying, in subsectors of transportation or within the healthcare world? I think it does to a point. But does anything come to mind that we should take note of now so we can include them into this type of conversation, or at least understand that they're working in certain areas or certain pockets?
I do want to bring up, if I may, I've heard the name Billy Parker numerous times. He's been, from what I understand, instrumental in coordinating transportation for persons with disabilities. I think he's with Chandler Gilbert Arc, and they've been working on this basically vehicle sharing program, if I understand correctly. And it seems like they've had great success with that. Parker.
Sorry, Parker.
Yeah.
Great. Yeah, thank you. And anything else we'd like to note from certain sectors or things that we just want to take note of?
It's interesting to me that there are no hospital systems represented today, and they're really the key with their discharge planning, and they have certain responsibilities to make sure that at least the person gets home.
That's a great point too. We can also put people who need to be or groups that need to be kind of included in this. And you said hospitals?
Hospitals, right?
I would say, first, let's look across the different state government organizations and kind of see who all needs to be included. There's a parallel that I think about with food insecurity, that it was a hard time. It's still an ongoing difficult challenge to get people to consider food or food insecurity to be health related. And so part of that is how all this came to be. So food stamps, for example, sit within the Department of Agriculture, not within Health and Human Services. And so to get them to talk, there's so much bureaucracy in between. And so if something like that exists for transportation, we should get people out of the health department and out of, transportation and wherever else, and just see who are the key stakeholders that need to be involved. And let's clearly state that we think barriers to transportation is a health issue. And that's why, we use the term health related social needs as opposed to social determinants of health or any other type of term, because it defines these things that are a little bit, further afield than traditional healthcare topics. It defines them as being health related. And that's a government tool that came out of the CMMI, CMS's Innovation Center. So as much as we can call transportation health related, I think that helps, build the case.
I'd like to suggest that we start with the three state agencies that I mentioned. They're the key agencies in terms of providing health and human services. First one is the Governor's Council on Aging. The second one is Aging and Adult Administration of the Department of Economic Security. And the third one is the Department of Health Services.
I think a big component that we're missing here for our partners is the staffing. of these drivers. If they're going to grow, do they have the staff, and not only the staff, trained staff, staff that can connect with that senior that's in a wheelchair, or can connect with that mom that has 3 kids that are just crying and they have to drive them. So staffing, if these agencies that we have now are going to grow, they also need to, they probably will struggle with staffing. And I think it needs to be somewhere in there.
And I'll I'm glad you brought that up, and I'll kind of share from our vantage point on a lot of times when we're going out there for grants and stuff, it's very centered around helping provide rides and building an internal staff infrastructure. We're fortunate for some of the partners that we have in which we can have those conversations that, yes, it's about adding vehicles and drivers, but also in adding internal structures that help us grow too, because we know we could add 50 vehicles tomorrow and still not even, meet half of the demand that's out there. But it's about, I think, strategically building out teams that, an example that comes to mind, and I think this was brought up in the other room, was that situation where an appointment is set, transportation goes to pick up, brings to the appointment and finds out that it's, for whatever reason, there is a miscommunication. I think something that would go a long ways for an organization like Elaine or other transportation services is having some of that navigation built in, because our drivers are able to a certain extent follow up with our clients to ensure that, we're calling them ahead of time, making sure that their appointment is scheduled, trying to figure out as many details as possible, but really having a navigation piece as well for somebody to communicate with the healthcare provider, communicate as kind of an in-between to hold someone's hand through that system and process, if at all possible, and keeping that communication solid, because I think that's where a lot of things can fall through quite easily. And then we have, people driving 2 hours to an appointment that, isn't happening. So that internal infrastructure is huge for us as well. But having, to your point, the ability to apply for the technical assistance and having those conversations with funders is huge for us, because without that, we can only grow so far.
There are philanthropic foundations too that are focused on providing money for healthcare gaps. And one of the first ones that comes to my mind is the Virginia Piper Foundation. Their focus is definitely healthcare, and so they would be a good player to bring to the table here.
I know that we reached out to Vitalist Health Foundation, and unfortunately they were not able to be here today, but I know they're another huge player in the whole state of Arizona when it comes to funding healthcare, Vitalist Health Foundation. So
There's one more I'd like to bring up, since earlier we were talking about food access. I know that at Desert Mission Food Bank, which is a partner with Honor Health, who we are also partnered with, they've been discussing food access in more detail and how it relates to health outcomes. They're actually attempting to set up a pilot program right now for food access for medically tailored meals. And I think the best contact there would be Sue Sadecki, who is just really, really passionate about medically tailored meals, health outcomes, and the transportation logistics around all of that.
What was the organization name again?
Desert Mission Food Bank.
Great, thank you. And I will definitely have to clean up this board a little bit, so don't don't mind some of the organization here. I'll make sure I clean it up a bit. It's also like kind of lagging behind, so hopefully we don't lose it in a little bit. But okay, so project duplication. So there's a lot happening. I'm going to make that more of a who needs to kind of be brought in, as this isn't exactly happening already. So, and we know that this isn't necessarily a product or even maybe it's a project, but not a product, but the task force as a whole. I mean, what does this look like? From this worksheet, we kind of wanted to take a look at from patient perspective, transportation providers, medical providers, tech providers. We also talked about funders. So those different sectors, how do they kind of get bought into this, and how do they support this task force effort? I don't think there's any right or wrong answers to this.
Well, speaking for ourselves, if I may, I think that one of our roles is just going to be providing data on the transportation need that we see out there.
Yeah, that was going to be what I brought up too. The Humanas of the world, Equality Health, Blue Cross Blue Shield, the healthcare providers. I mean, I'm sure the data is vast that exists that really paints a broad picture of what the needs are, and then taking that data and building a case around how transportation specifically is going to help address those critical challenges and issues that the healthcare providers would see. Because Elaine has data, we collect quite a bit of data, but it's going to be nowhere near what the healthcare providers bring. So I think a more nuanced conversation around what the biggest challenges that they see are, and I'm sure there's quite a bit of overlap in what those challenges are, really can start the conversation to start identifying how access to healthcare, access to food and other resources can help address what everybody is seeing as just the main challenges.
One of the things I see when you're talking about asking for data to get data points is, especially when you're dealing with healthcare plans, like Humana's, they're like, okay, HIPAA,
Yeah.
they do HIPAA violations, and I'm like, okay, I know you can edit the data where some of the HIPAA, well, anyway, there's ways to get around that, but they're too scared to. I mean, not too scared, but that's where I get blocked all the time. Is, hey, I need some data here to show that this is why I need to fund this grant or fund this process, and they're like, well, we can't get that data to you because HIPAA violations. Then I have to go into my my lawyer voice and work with them that way. But it creates a lot of barriers. So anyway, so that's one of the things I see, because there's a lot of data out there. There's data everywhere. But the point is, especially in this population, because everybody has to report on something. But they're just worried about, a lot of HIPAA stuff and all those kinds of things. So it's about finding creative ways to get around those barriers too. So we can do that or help with that anyway.
Yeah, I think that you're onto something, because when we used to work in a program before we got acquired by Centene, it was when we were working for WellCare. And then we would go to all of the community-based organizations and CBOs and look at their kind of like their intake system or their screening system when anyone from the community goes to a CBO to receive a service, whether it's food box, childcare, whatever they're offering. We would always look at their screening system and look for a couple questions. One of them, are you asking everyone that comes through your program, do they have health insurance? The answer is usually yes or no. If they say no, they probably have a partnership where they can refer them to an application assister, or maybe they have someone in staff that can help them fill out an application. And then I would ask them, what if they say yes, they have health insurance? He goes, oh, that's great. We'll kind of move on. I said, no, the next question should be asking them which health plan they belong to, because that's going to help that CBO collect data on that specific health plan without having to get into any PHI or, HIPAA regulations. Just asking them, you have health insurance? Yes. What plan do you belong to? That's it. And I think for the CBO, it becomes very valuable, trackable data. You can start seeing, okay, how many of the people that come through Elaine or through the food bank every week or every month, we know we have 50 people from Care First or 100 people from Humana. You start getting that data, then you contact those health plans directly and say, hey, how can we work together? Because we know for a fact that we have 400 participants that come through our doors every month that belong to your health plan. How can we work together?
I'd also like to follow up with just what we found very helpful at Elaine is that we just made the decision to train all of our drivers in HIPAA, because there were enough situations that came up where hospital staff needed to share information about the patient in order for us to provide the transportation service.
How, kind of on the data sharing piece, how does that currently work and function between transportation provider and like the health plan? There are instances where that works well, it doesn't work at all. I mean, it should happen. I'd imagine it's kind of all those things, but depends on if you have a good partnership.
Well, I can say for the health plans, they're a contracted provider. So part of the contract is receiving that data. And I don't want to speak for every health plan, but I'm assuming just from our health plan, when it comes to the grievances, transportation is almost like at the top of the list. I would say that every health plan probably has something very similar. So the data is being collected, and is usually because you're using a contracted transportation provider or providers or brokers that provide that service for the health plan. But it's not general data that includes all of the health
Yeah,
plans.
I
It might
think
be
you're
through
right. I mean,
Access or someone like
We
that.
work with Motive Care, used to be called, I forget what they used to be called, but Motive Care is kind of this big national plan. So we manage them like any other vendors. So there's bidirectional data communication between us and that organization, but it doesn't include people that aren't on our plan. And we don't share any data that we don't have to. I mean, the reality of it is, and you know, not that I have any experience with this, but I think sometimes health plans could hide behind the HIPAA issue, because data is a competitive advantage. Like there's inherent value to data. So I know our organization is very reluctant to share data outside the walls. And that includes with CBOs, but what I think we could possibly do as part of this task force is think about ways around that. And you can de-identify data. You can use it for, fit for purpose kind of things. It's for this project only, and then we get rid of the data. There are ways to do it in a way that would not become a competitive disadvantage for a health plan like ours, and aids everyone. So something to think about. You could do unique identifiers, de-identify stuff. You get, say, all the health plans in a state to agree to do it. And so it becomes more like a utility as opposed to something that you compete on. So that could be sort of a topic within the task force that we debate about. What are the appropriate ways to share data, or how do we get everyone comfortable sharing a degree of data?
I think that's a great point. Something very similar to what you just described took place when it comes to housing. When all of Texas health plans came together and they said, we have this great housing crisis in Arizona. I know it's nationwide, but at least in Arizona, all of the Medicaid plans got together and they came up with each one of the health plans is going to give X amount of money towards this housing fund to fund different projects throughout Arizona when it comes to underserved populations and housing. So there might be something similar that can be done around transportation and not just housing only, where all the health plans come together and say, hey, we have to do some community reinvestment dollars as a health plan. We're willing to, as an example, each one of the health plans will give $100,000 towards the transportation needs of our population. So maybe something around that where all the health plans kind of identify transportation as a great need, just like they did with the housing. That might be an option where everyone can come together and.
Yeah, I agree with you. And I think even there was an article in Health Affairs recently that talked about how to create social impact bonds, where you can get multiple people to pool money like you described, but there's actually a mechanism for payback if whatever it is successful. If the impact is there, then the organizations get paid back. So it's not even a sponsorship or a grant. It's actually an investment that you can get, competitors to actually go in on together.
Another statewide group that we haven't talked about is the Association of Area Agencies on Aging, and they have access to the federal Older Americans Act money, and they have a lot of discretionary funds, even though it's based on their annual plan. They could revise their annual plan somewhere down the road, and they are a statewide group.
one thing I wanted to go back to was kind of on that, I guess the Z codes, but how do you kind of associate a fee for service model, like you kind of talked at the outset a lot in the other session. How could this task force kind of help overcome any of the barriers associated with that and allow effectively the transportation provider who's providing a service for a medical facility to bill, but also then recoup some of their costs associated with providing that service? Can we talk more about what that looks like here, where it works well, where it doesn't work, and how we, any barriers that currently exist to making that more of a universal kind of model in our ecosystem?
I would suggest just starting with a pilot, kind of proof of concept, and see how that can be scaled. I don't know if Elaine, with any other partners, are you guys looking at that in currently as far as Z codes and how that could be incorporated into transportation that you provide?
We have briefly, if I may, Erica, we have briefly looked into Z codes, and I think that is something we will aim for when they become billable. As they are right now, obviously, the type of transport Z codes that exist are not fee for service, they're data oriented. So we've put it a little bit on the back burner, but definitely of high interest to us.
Thank you.
We did a pilot actually during the pandemic, so it was a little dicey on participation, but where we worked with some specific value-based providers, and we would pay them, you know, certain amount of money if they would screen for a social need, document a Z code, and then document that they made a referral. It was reasonably successful, but very manual. That was a big part of the problem, is that we needed spreadsheets. I mean, we were talking about Excel documents, totally, you know, ridiculous, but that's what we had to do for a pilot. So I agree, starting with a pilot makes sense. But you've got to figure out, how do you get to scale with it? How is it integrated in the EHRs? And how is it, you know, all that.
If it's something that works well, we could partner up with something like that. We already have the platform. We have our own platform called Care Empower, where we document all that information. So this is where all the information of the providers lives in there. So if I go to a specialist, it's in my PCP's platform. If I go and take your service and you're a community based partner that you've partnered up with Equality Health, you document in Care Empower that you gave them a ride. So all that information lives. So if there was an agency like Equality Health, we could do it because we already have everything in place. We have the screening, we have the Z codes, we have, you know, we have the platform, and so it could work where we partner up with. If you would like, we could start with somebody like Equality Health. We partner up with a lot of the health plans.
I'm glad you brought that up, because one of the challenges working with CBOs, as I mentioned earlier, we want to meet people where they are. You could have a great CBO that provides great services, but sometimes there's challenges when it comes to technology, because maybe they don't have the funding for a big platform where you can track everything electronically. A lot of it is done through spreadsheets. Some of them use paper and pencil. That doesn't diminish the value that they bring to the community, but we have to be mindful that some CBOs require additional attention or additional resources just to get a computer or a tablet, or helping them kind of integrate into where we're going. I don't know how it is where you are working with the tribal communities. You mentioned there's challenges with broadband technology. And so you may be using pencil and paper or a spreadsheet just because that's what you have to work with, but it doesn't take away of the services and the programs that you're providing in your community. And we see that a lot. So we have to be mindful that in order to help those CBOs kind of get to the next level, they will require that additional attention and support as well.
So is there anything that's great? That's like a kind of clump that together as a little potential side project. Is there anything within this, kind of going back to the task force on that particular issue? The Z codes are helping kind of instigate that type of project or other that could be beneficial. Like, how could this task force kind of help make sure that that is implemented or kind of come to life?
I'd want to jump in and say, I think this would be a fantastic area to focus on, just putting a lot of energy and attention into Z code transportation, because, people who say it's going to be billable in a few years, but I think things that are getting more attention and energy put into them now are more likely to become billable sooner. So if we're talking about putting together another pilot, Eric, I don't want to speak for you, but that's something that I would have a great deal of interest in.
Well, I would say that Z codes are technically billable now. They exist and they can be billed, but we and other payers don't pay them now. So, you've got to get payers willing to put money behind them. You've got physicians need to start screening and documenting the codes, and then you start this virtuous cycle with it. So I wonder if a role of the task force could be getting consensus on which codes to use and when, and what an appropriate reimbursement amount is going to be, that sort of thing. You get all these stakeholders involved and some consensus. And if there is any degree of authority where you could put that out there, and that's the expectation, then that would be a really good output of
Yeah,
that.
I agree with that. Because, when we talk about Z codes, we're talking about a lot of information. What if we're just going to focus on transportation only? It really shouldn't be that complicated. Because if we just focus on transportation and not on the other Z codes, that's a good starting point. Because then we don't want CBOs to be overwhelmed in thinking that they have to become healthcare providers. I know every Z code for every social determinant of health, that's not realistic, and I wouldn't encourage that. But if they just want to focus on their core services, even as a pilot, on transportation only, that will probably simplify the process. And then that's when that technical assistance that I was talking about, maybe building the Z codes like Equality Health into their screening form. So when they're marking something, they don't even know what the Z code is. That's already been done for them. They just have to check a box.
Yeah,
You know
we
what I mean?
actually have the screening tool, and the Z code is right there. It's the question, and then there's a Z code there. There's nothing, anybody in the front office could document that, because it's done for them. For every question, there's like 15 different questions on different areas. And the Z code is on there. So we've done all the work for them.
So within that's the intake process or scheduling, patient scheduling?
It's for the, so we work with the providers. So the providers give that to all the members that we share.
Okay. Cool.
And do you think something like that could be built for the CBOs?
Most of the ones that are there are billable,
Okay.
but it's like you said, it depends, but yes. And if they're not, we're keeping data to show, we're keeping all that data to prove, because we're working with Access, we're working with the health plans, we're working with the decision makers at Equality Health. Not me, but, people at the organization are working with these decision makers. And so it's our job to prove to them, this is what's happening. So we've been working on it for 6 years now. So we have quite a bit of data.
I'm sorry, what's the name of your organization again?
Equality Health.
Quality Health. Okay. So that's essentially exists for 6 years now, lots of data. We need to then kind of, through the help of the task force, kind of bring together the payers who will come to an agreement on what that reimbursement rate actually is. So that hasn't been defined yet, sounds like. Okay.
One of the main identifiers as far as successful of a program or how you measure outcomes. I mean, there's a lot of different formulas, but usually if you can tie anything to the utilization of the ED, like if the service that you're providing is preventing that person from going to the emergency room for whatever reason, that's useful data that all the health plans look at. Also, if you can prove or come up with a formula that the service that they're receiving is saving cost to the healthcare system, that is another measurable that you can include in data. So for an instance, I know that if I provide transportation to this member, it's a cost savings of X amount to the healthcare system in general, and it's saving X amount of ED utilization. that's some of the data. We kind of got to get into that. How do we talk the same language? Because CBOs may not be familiar with that language, but the health plans are. So how do we come up with the terminology that everyone understands what we're talking about?
Well, and I would go a step further. I mean, I love that idea. I would go a step further and say maybe another output of the task force could actually be to commission a white paper or a study of some kind using the data that you might have and say, what is the impact analysis of providing transportation? Can you quantify it in fewer missed appointments, fewer ED visits, hospitalizations, stabilization of chronic diseases? There's a lot of different ways to, assess impact or value. But commission a report on that, and then have it out there, aggregate all the evidence that we have, do a literature review. That could be really impactful and be a good step towards actual funding and, reimbursement.
And that's immensely helpful for our organizations, as you mentioned. I mean, we're partnered now with Honor Health, and part of that contract we have with them is that data sharing, but that comes over the course of an entire year. If we had a plethora of data that we can point to from a wide variety of, healthcare resources right now that we can utilize to go to providers and say, hey, here's the data. I mean, that helps us out a lot. Because we can only do so much footwork on our end in terms of our limited partnerships. But if there's enough buy-in from, the big players, that's all the help that we would need to go find funding from Virginia Pipers of the world and different organizations that would be interested in working through that with us. So
I think that's the buy-in on the CBO side, having access to that data so they can leverage additional funding that they probably wouldn't be able to qualify for because of the lack of data. And that's when those grant writers and that technical support comes in. Most of the health plans already contract with the grant writers and things like that. So I don't think it's a big ask. Instead of providing a sponsorship, maybe providing a grant writer that could help them gather that information and show the impact.
Hi, everyone. Just want to say it's 1 p.m. Okay.
Thanks, Hezekias. All right. Well, it's 1 o'clock. I think everybody else can at least break for a minute. We have the opportunity you can come back here. We can continue this conversation, kind of dive into this or any other little things the task force could work on. Still a lot to flesh out here, or you're welcome to join another group and kind of just see what they're doing and add to that conversation. But this has been great so far. So thank you. But we'll meet back here at my agenda. I think it's only 10 minutes. Yeah, 1:10. And then we'll continue on for about another hour before we go back to the main group.
My business card, if you can send me your contact information so that we can continue our conversations. Are you like medical? What is it? We work with the health plans and we work with the providers. Oh, okay. So to the health plans, we say, give us your sickest patients and we'll keep them. For the providers, we're saying we'll help you be more successful. So we're helping them integrate into value-based care and helping them with their sickest patients, the most vulnerable populations. And so in keeping them healthy. Because a lot of times there are small entities and they don't have staff and they don't have technology. And so it's part of the problem. Yeah, we had this conversation about health insurance providers, out there on travel lanes, this is what we're thinking is there has to be insurance folks, healthcare providers or health insurance providers are able to buy the folks more items in terms of like transportation,
hearing aids, dentures, a lot more in terms of helping them. Whereas all they know right now is when they're asked who their healthcare provider will be, they pick IHS. Well, IHS doesn't like to give anybody anything. So therefore, the folks are just being.
Yeah, so
Yeah.
one of the things that we, our care coordination team, anybody from the community can call and say, these are my needs, this is the health insurance that I have now, whether it's Medicaid, whether it's Medicare. And our care coordination team will help them based on their needs. If it's Medicare, we refer them to a broker, a Medicare broker, because we're not the experts and we're not. If it's Medicare, then we just kind of.
Looks like it might just be us. Again, did we? I didn't see the other rooms. Makes sense. Well, I'm glad people are rotating. It's important to see all these, but we still got Sam. Hey, Sam.
Well, actually, if I may jump in, I actually am going to switch to communications. I'm so sorry.
Fair enough. You totally should. All right. Yeah, thanks for participation.
Work within our group to keep it moving. I think that's the most important thing, having a focus group, focus on a single task is important because we're talking about gaps, and challenges, but the system changes so fast. I mean, you guys were talking this morning. I'm like, I took a lot of notes because you guys had a wealth of information this morning, and I could see everybody writing things down or, taking a picture of the screen. But I think it's really important that we work within what we know, because only, like these acronyms that were being thrown out, I'm like writing it down. What does that mean? And the purpose of it is sharing that with people who don't know. I mean, they were talking about a navigator, digital navigator in the other group. And one of the things that they kind of pointed out was you can't have just one person know everything. That would be the hardest part. So their thought was that if a driver went out to the consumer, was able to bring, a tablet with them to connect to somebody who does know. And that would be these guys, be this group, to connect to somebody who does know. That's a lot easier than having somebody who is supposed to know it all. Because we're talking about staffing. How are you going to, find the staff to know this information? I don't, who knows your job better than you, I don't even know my job sometimes. I look to you guys.
Yeah, I think a big part of all this, not only in the conversation that we've had here, but in the big room, sustainability, and I think Z codes. People are interested in how can we bill for this so we can get reimbursed for a service that we already provide? So we're not reinventing the whole wheel, we're just providing that technical assistance and support. And how do you get compensated if there's a mechanism for the services that you already provide? So that's a big part, I think, of the conversation.
Yeah, we had a lot of ground to cover in only an hour, and we're kind of in the same position now. We're at 20 minutes into this session, but so we landed obviously kind of carrying on from the main group to, we talked about kind of project partners in the duplication section, but which could be an immense number of folks in this task force, but the Z codes was a big one. How can we kind of standardize and make it so that they actually get paid, people know how to tap into them, appropriately bill, and then from that we also kind of narrowed in on how to make it sustainable and prove its worth and value, was to create some sort of a white paper or study that, that reimbursement and that fee, how that could, what is the actual outcomes and how does it hopefully maybe create a return on that investment. So not just the delivery of it, but also long-term, how do you then leverage that for additional funding for CBOs and the like? So that was the biggest focal point of our discussion. We could continue on with that, but we also talked about how do we leverage data, access data, that there's kind of a wealth of data, but it kind of gets caught up and hard to access because of HIPAA. How do we collect it and de-identify that data so that the task force can kind of understand challenges and also maybe opportunities and analyze the data? So that's kind of its own little thing. And I think that's kind of all we got. We have a social impact investment from a health plan. We kind of quickly changed gears on that one, but those are our three big bullets. But we can continue kind of fleshing these out if you'd like, or take it another direction if you see another avenue that the task force could potentially focus on. Anything is okay for right now.
Question. You guys talked about Z codes, like we talk about CBOs and we're talking about healthcare. So healthcare is not a station, but like say these small CBOs don't have CHWs, which for now I don't think CHWs would be able to bill for transportation anyway, even though they're using Z codes. Like, yes, Z codes are important, and I see, yes, we should use them, but other sources of revenue for those CBOs when they provide. Oh, sorry.
Oh, yeah.
So I don't know if you guys talked about that.
We touched on it a little bit. My question is, do you work with any CBOs that just focus on transportation only?
I do not.
So that was one of the things that we brought up because, when we talk about Z codes, I mean, Z codes could be all over the place.
Yes.
But if we're just focused on transportation only, not that that should be the only focus, but there can't be that many transportation Z codes, right? So if you're working with like an organization, kind of like Elaine, that the main core is transportation, it shouldn't really be that difficult if they just focus on the transportation Z codes and not all the other ones that are, homelessness and food and everything.
Yes, but I feel like, if you're with an organization that connects those resources to, like, there should be also reimbursement.
Yeah, but as a small pilot, just to kind of show the transportation impact.
But then you're also using
Because
FTEs to staff that.
I know that CBOs we want to eventually get them maybe to understand Z codes like providers, but at the beginning, it's a challenge for them. I could totally see implementing other Z codes for those wraparound services, which is what we want to get to. But if the main focus is transportation, maybe a small pilot just focused on that and whatever data is available, that could be a starting point for that, like the white paper that they were talking about. Then we get into all of the wraparound services. They can track it, but I think the main focus is transportation, right? The conversation.
I'm just saying reimbursement on both ends,
Oh,
not
yeah.
just one. That's
I
where
mean,
I'm
on
trying to
all
go.
ends if
Yeah.
possible.
Yeah, yes.
Yeah. I think that's a question for like the task force and where do they need to start? Is it more focused transportation? Is it more holistic kind of approach?
Yeah.
What is their capacity and willingness? So yeah, I don't have the answer to that, but hopefully in the end we get there. But yeah, where do we start? And that's actually a good natural place if we don't want to introduce any other ideas necessarily. One thing we didn't get to, these might not kind of pertain to our conversation, but first steps and next steps with this. So if we are choosing to focus on kind of this operationalizing, building consensus around a Z code, what would be the first step for the task force to make that happen?
Yep. What's a Z code, and start from the basics.
Sorry, so what is a Z code? Okay,
I
understanding that.
I think that's really important because I heard some acronyms that were taught, brought up this morning. But I come from kind of the human services transportation side, and some of those acronyms are different. I thought I knew what you guys were talking about, but they were different from where I was coming from. So I think that's really important.
And a lot of the conversation centered around being able to know how to communicate across transportation and healthcare and all of that. So a glossary or something like that to
Yeah, I think
Just
sometimes,
explain.
especially with CBOs, their language might be different from healthcare and it might be different from transportation only. So how do we speak the same language so we all understand each other?
Is there already like a directory or kind of a reference sheet of your?
Yeah, I'm gonna provide that for the group. Actually, Access, the state Medicaid agency, has a list of Z codes.
Okay.
And they've already developed a tool, 6 years worth of data. So I don't know if they're willing to share some of that data, but they already have a tool that they're utilizing that has already, and I don't want to speak for you, obviously, but the Z codes related to the services that CBOs provide.
So ours is a SDOH screening tool. And so it's 20 questions. And when, so if the person says this, they have trouble accessing or having trouble maintaining their medication regimen or whatever, that's tied to a Z code. If they say most of the time or always, then that's tied to a Z code. So then in the community cares platform, they get a drop down menu because the member said most of the time or always, they'll get a drop down menu to put in what's with the Z code that is most pertinent to that question. If they say that they don't have trouble with taking their medications, then the Z code won't come up. So that's already mapped out to Z codes, that 20 question survey, but it has to do with social determinants of health.
So through that process, I'm just trying to figure out how through that process, you only draw out that information that would need further, assistance or support.
Yes, so based off of those, they ask those questions, depending on how they answer those questions, then we identify their needs. And we're able to tie the Z codes to them and make the referral to the pertinent CBO or resources that the individuals need.
Nice.
And that's for providers only, right? Right now at this point, or the CBOs use the
No,
same
our
screen?
CBOs, yeah. have
So
access to it,
it's
yeah.
something that's kind of already built that
Mhm.
could be incorporated.
And I want to write this down. Which organization are you with again?
Equality Health.
We're piggybacking on Maria. She-
Totally fine, totally fine.
She was here before you.
Oh, she's awesome.
Okay. Earlier also had one of the health plans say that I think from the health plan perspective, they need to figure out exactly what the task force needs to understand like a rate, a reimbursement rate, what that is. Sounds like they don't actually have a dollar amount fixed to that. So really understanding what that reimbursement rate would be is going to be crucial.
Did they talk about, because I know some health plans reimburse for transportation, and we saw that a lot during COVID. Did they talk about, like, is that going away because of the public health emergency going away, or is that just Do they plan on keeping it?
The gentleman from Humana said they started a pilot during COVID, but he
Uh-huh.
didn't get into details as far as whether they're continuing the pilot that he was talking about.
Yeah, I don't remember what he said.
Because you're right, with the public health emergency coming to an end this month, actually, they actually started disenrolling Access members April 1st.
Yeah.
A lot of those flexibilities that came with the pandemic, as far as even telemedicine and telehealth, transportation, I don't know if the health plans are gonna make a decision to keep that because it's been something that's been good for their members, or if they automatically go away when the public health emergency ends, where those flexibilities may not be there anymore.
From a healthcare, oh, sorry, go ahead.
I think like it's probably not even a helpful answer, but before the pandemic, insurance companies had been starting those experiments anyway. So at the broadest level, they're generally seeing the value in transportation and I think figuring out how to fund it. I don't know what's happened still goes back to the I don't know with the end of the emergency, but it's at the very least been on insurance's radar for a while.
Yeah, and I don't think transportation as a benefit is ever going to go away for healthcare because it's part of a benefit for the Medicaid and Medicare population. Transportation to and from medical appointments is a covered benefit. But as we talked about, the coordination and the training and the consistency is not there, but that's not going away for sure.
As you talked about the disenrollment too, like people being unenrolled from Access, like, so now people don't know that they don't have health insurance and they don't have transportation either. So that's, how's that being communicated is probably.
We were talking about the whole something years to go through the whole process. We'll get a letter saying that disenroll have new options. The problem with that is some of those people that don't have the right address or stuff like that, so they'll just lose.
And those are the folks I'm talking about, the people that probably lost their homes during the pandemic. They're probably on the street or going from one family member to another. That Access has no idea where they're at and they don't have the same phone number. So it's like those individuals that now, like I said, they don't have access to healthcare or transportation, period. So I know Access has been trying to do a very good job of communicating that to individuals, but it's only so,
My experience with Access is the communication things suck.
No, it's true. And part of that not only is because of the population that we serve, they move a lot. They don't think about calling the helpline, say, hey, I moved, here's my new number. But then there's another layer because of the pandemic for the last almost 3 years. They didn't have to renew. They didn't have to submit any paperwork. It was just automatically renewed for 2 or 3 years. So people just kind of got used to, hey, I don't have to do anything, right? But the worst part is when they, like you were saying, when they go to the doctor, when they go to the emergency room, that's when they find out, hey, I don't have coverage anymore. That's like the worst time to find out that you don't have any more coverage. That's another layer that's going on right now. And this is going to be going on for like 9 to 12 more months because they're going in waves as far as the disenrollment goes. So they started with the over income folks that were the Access knew that they were over income. So those are the ones that they're going to start disenrolling first. And then they're going to start going in waves as far as not receiving, sending a letter and it's going to the wrong address, unable to contact. They have a phone number, but it's the wrong number or it's disconnected. Unfortunately, like you were saying, those people are just going to drop off, even though they might still be eligible. So we're going to go through that challenge for the next 9 to 12 months to see kind of where we land.
And I think this is where the SDOH fits in the healthcare transportation. So just tying it back into why it's brought up. So maybe like education in the provider offices too, just to make sure that, you know, letting their patients know about these things while they're there, because maybe 3 months from now, when access gets to them and they're no longer eligible, that, you know, that conversation with the physician assistant, like, hey, I see you're on access, is all of your information updated? You know, making sure that all the boxes are checked.
Yeah, all of the health plans have been doing exactly that. And actually, the health plans get a list from Access of members that are assigned to that health plan that they have not been able to contact. So then we use that list and we look at the providers. Hey, this is a list of your providers that Access has given us that they're going to lose their coverage. Can you reach out to them, or next time they go to the doctor's appointment, can you remind them? Because if their phone number or their address is not good for them, it's not going to be good for us either, because we basically share the same information. So we are relying on the providers and also the CBOs. If we can identify some CBOs, like we know that our Care First members are going to this food bank once a week or once a month. Hey, can you just remind them that this could be impacting them? So those networks and that information is being shared, but unfortunately, there's still going to be people that fall through those cracks.
I feel like you're talking to me because I have a community group that comes together and we share resources and information they should know. So even though we put this information in our newsletter that goes out to our nonprofit providers, you know, like Gompers, you know, Hacienda and stuff like that, I feel, I have a feeling that, you know, sometimes the information is slipping, you know, through the cracks. So I may reach out to one of you to maybe just do, you know, a reminder at our next TAP meet. Sorry, I have a TAP meeting in June. I believe it's on the 21st. But, you know, just brief, you know, presentation on the importance of this. I know we put in our, and it's mostly nonprofit providers. We have municipalities there. We have, you know, our nonprofit providers. We also have some state agencies, but I think this is so important. And that's my thought, is that people may not get the information. Like we had our, I think it's Laura Thomas from Maricopa County, even saying, you know, if you get a letter, open it, you know, because people, especially older adults, are very hesitant of opening stuff that they don't know where it's coming from. So I think just this one little aspect is so important. Sorry, go ahead.
So I added provider, like from the office education, CBO education, resource navigation, referral, education, all those things that go in kind of supporting the patients. And
Okay, I know in the category, no stupid question. What's the CBO?
Community-based organization.
Thank you.
All right.
Another acronym.
lots
Or
of
sometimes they're
acronyms.
called nonprofits or.
Okay. We call them providers, whether it's any nonprofits, we just say.
And you know, that goes back to having the same language, because if in the healthcare world, you're talking about a provider, you're talking about a clinic or a doctor, or
See, yeah,
Yes.
a provider could be a totally different thing.
yeah. Ours is not any nonprofit that provides services.
Okay, so okay, we have a number of things here. Any other thoughts on kind of high level activities that need to be done that the task force can kind of help push or coordinate?
How about having a criteria of identifying CBOs? Because, you know, as we've mentioned, CBOs could be at different levels. But if we want to do a pilot or something, maybe a criteria of some components that kind of have to be in place to select the CBO, like for a pilot or something. Because some of them are, like I mentioned earlier, some of them have challenges with integration with technology. They may not have a platform. Maybe they're using pen and paper or Excel spreadsheet. but maybe some CBOs that might be a little bit more mature and advanced that could do some of the tracking and meet some criteria, I guess. And we'll meet them where they're at, just knowing, identifying which ones would be, make good partners for like a pilot or the white paper, that have some data and to collect and analyze.
I think that's really important because speaking from the transportation side, we have providers who are doing their scheduling on pencil and paper. Some are using Excel spreadsheet, and then some have the software to use. So there's so many different levels in just that one little aspect of it. So I think it's important to talk to where they're at.
And a lot of the CBOs have volunteers. They don't, the majority are volunteers. So training is an issue. You may have a person that only shows up on a Wednesday from 12 to 4, which is fine. I'm not, but there's staffing challenges when it comes to CBOs.
What about things to like just general best practices kind of on anything, but patient or consumer outreach, how to engage with like that hard to reach populations, varying level CEOs and their capacity they might not understand kind of like certain nuances to reaching certain populations.
I think we talked about a little bit the big group. We talked about putting stuff in plain language or grade level that people can understand, I guess. Because so many times we use like our legalese or acronyms and things of that nature. Not everybody's gonna, even us ourselves don't understand what those mean. So if you put everything in plain language, plain language means a lot of different things to a lot of different people, but it's a language that people can understand or easy to read language, I guess. And that might be helpful.
A good point that was brought up early with the redetermination. I know Access has created a toolkit, maybe creating a communications toolkit. Because I know the health plan we are currently using texting, emailing, direct phone calls. We're sending postcards in the mail. We're working with community-based navigation assisters organizations. So it's like a multi-prong of just getting the word out and maybe coming up with like a communications toolkit or something like that to disseminate information. Social media.
I see there you guys have identified Taskforce partners with activities of that. Like I think data is also like, what data can stakeholders bring to the table that would help us create those goals and activities? So it could be a targeted approach. And I turned off my mic again, so I'm sorry, I didn't capture that.
Oh, no, when it's green, it's on.
It's red on mine.
Oh, okay.
I hope it was far. I spoke. loud enough.
I'll put it over.
I forget. I'm sorry.
I just leave mine's on.
Does that capture identified data that partners can bring to the task force or
So yeah, so we
Board
can
efforts.
align it with our goals.
Yeah, I will have to clean up these stickies a little bit after this meeting, but as long as it's on here, I'll remember. Okay.
I don't know, we talked about bringing the government agencies that we need to, I guess we did a little bit, but so the first steps would be identifying what those agencies are, government agencies, because I don't know, maybe, I don't know, like Access is definitely one of them we should look into. Yes.
I agree. I think it's important to also, who's, we're here, but who's not at the table
Yeah.
here that should be at the table.
Yeah.
Listening to this and telling us, yes, we can really do that or no.
Could that be the next step if everybody who was here today kind of forward their contact people? Or who should be here? Who should we invite? Who should Ezekiel start making phone calls to?
Yeah, we had this earlier, but we kind of jumped right into the exact like activities. So it's important to come back to this, but suggest like having starting to compile the contacts, I guess.
Like a directory of participants.
sure there's a lot that we don't have time to get into all of that right now. Another one that we kind of skimmed over was what resources can be offered in biome, and we kind of talked about it, but if there's anything you'd like to specifically state on here, toss on there. As well as the funding.
I think, one of the missing pieces from the CBO side, obviously sustainability is an issue. And then there's like the one that's a little bit, it's gonna take a little longer with the Z codes, right? But what could they need that could be provided now? Is it like gas cards for their volunteers? What kind of solutions are like long-term and short-term? I know some of them might do like mileage reimbursement for their volunteers. Is there like an opportunity to sponsor or donate money or provide gas cards? How about, do they use their own vehicles? What about the maintenance? Do they change the oil? Do they need tires? I mean, I have no idea what,
There's a grant program for that.
and I think
That-
CBOs need to be aware of that,
And
like short-term solutions versus, long-term sustainability.
that's a program that here at MAG, we oversee. It's called the Section 5310. It provides those reimbursement for mileage. It provides preventive maintenance for those vehicles. The only problem we have, a lot of the barriers that we see with nonprofits is that it's a federal program. So a lot of nonprofit
Paperwork.
agencies aren't, there's a lot of reporting, a lot of federal compliance that they have to keep up. But we're here to support them. We want to get this money out to the community. But I think that's really important on the sustainability. And that was talked about in the other room too, about the sustainability part.
I'm wondering, I know for other nonprofits, there's like the nonprofit that provides the services. And then they partner with like a larger organization that falls under that umbrella that takes care of all the administrative parts. Kind of like a fiduciary, I guess I want to call it, where they're in charge of like billing, grants, like all the administrative stuff, and they just kind of let the nonprofit do what they do. I wonder if there's like that middle fiduciary that has all these CBOs underneath, that one entity can help them with that technical assistance, the grant writing, and to kind of take that. I guess in some ways it could be a burden for them because they're just so focused on the services that they provide, but maybe they can take on that administrative role and the tracking and reporting for that organization, or work with them in making that process easier for them.
Administrative support for CBOs, something like that.
Because sometimes that's the big challenge, especially with turnover, volunteers, lack of staffing. That is a challenge sometimes for CBOs.
Yeah, absolutely. So we'll let the CBOs do what they do best, do their thing.
Let them do their thing.
And then
yeah.
have the administration. Yep. Okay. So I've never heard of that.
You want to talk about some sort of data utilities stuff for the next step, or do we?
Say more about that.
So we talked about, because earlier, like, in the first session, or in the last meeting, we talked about how all the healthcare companies have data, well, because of because they want to keep their own data for economic purposes, or for, so it kind of, but we talked about maybe making some sort of utility where so it's not so HIPAA, like there's no violations or anything like that. I don't know if I'm saying what the conversation was, but we talked about that a little bit.
Yeah, no, thanks for reminding me. Yeah, so like de-identify the data, share data across these entities so that we kind of get a better idea of, I guess, what's happening in our ecosystem.
I guess we can use the white paper.
Okay. I'm gonna go back up here so we can see that. Perceptions. Yeah, we had someone share about the built environment. That's a certainly a big issue.
Is it on the third?
Feel free to chime in if you see something that catches your eye. So I think the de-identified data was in here. De-identified data and aggregate data for the task force. Okay, that's a good one. Then this is the Z codes, CHW reimbursement. Okay. We talk about training drivers and staff and just, I guess, I don't know, sensitivity training or HIPAA compliance. This has been the first thing we said, but I don't think we said it since. I guess that could kind of fall under like best practices or something. That we
Yeah, I
shared.
think Elaine and the Verde Valley caregivers, they really do a great job in training their volunteers and their staff in the population that they're serving, where, you know, they're gonna need a little bit more patience with Medicaid or access population, maybe speak different languages, having their staff, you know, be more in tune of the population that they're serving.
I have that twice. All right. A lot of activities.
How many people are on this task force?
Yeah. I guess that brings us to our other question about just task force administration. I mean, somebody needs to lead it, right? Or how would that look across the state?
Maybe identify lead agency or agencies.
Yeah.
And I don't know if you want to break it down by regions, because, you know, the whole state might be like, maybe like the way access is divided as central, north and southern Arizona. And then bring all that information together for the whole state. I don't know.
Yeah, those are key administrative decisions. Right, so we kind of have more internal processy type of next steps.
And then how often should we meet? Is it quarterly or?
We have to establish bylaws, stuff like that.
Yeah, all that fun internal processes. Yeah.
You volunteer?
Right. Quite the list.
Start working on it, to be honest.
Yeah, we could talk for days.
And I was at another one that has stuff that they're working on too, so think we got our hands full.
Yeah, how do we bring all the other workers together?
Yeah.